Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello and welcome back. This is Adam Rosen, and this is October 15th, 2021. I have the pleasure of sitting in front of my esteemed colleague who has been the previous head of the Department of Orthopedics here at Scripps Clinic for over 25 years. He's also the past president of the Knee Society and AAHKS, Dr. Cliff Colwell. Good morning.
Good morning.
So for those of you that are listening in to this one, if you haven't already listened to the first episode of our discussion, check back and I'll put that in the show notes. But there were a lot of other questions that we wanted to cover, and Dr. Colwell was nice enough to sit back down. So we're just going to jump right into it. And I brought you a little present because we were going to talk about fellowship and fellowship training. So just as a reminder for you, I actually printed up the list in chronological order of all of the fellows that you've trained over the years. So back in 1984, was the first fellow that you trained here. And you had one fellow for a number of years up till 1992, which is when you started having two fellows. And then in 2003 is when we started here with three fellows. So I was just kind of curious, what it was like training all of those fellows for all of these years and, seeing all those names in front of you of all those surgeons that you've trained.
It's fantastic just to look at these figures and the names and remember portions of each individual. The desire to train fellows came actually early on in my career. I started as a private physician in private practice in San Diego, California, at a private hospital here, along with a couple of good partners. And for the first 5 years of my practice, I was very satisfied with just taking care of people and had a varied practice, included a variety of different problems. We were trained as residents to be able to treat all orthopedic problems, all the way from foot problems to neck problems and everything in between. And a lot of it was trauma related. When starting a practice, there wasn't really any need here in San Diego for a new orthopedist. On the other hand, older physicians didn't want to take emergency room call anymore, and were looking for somebody to take over for them. So getting an active practice was really, really easy. You just took their call for them, and the trauma came to you, and then those patients told friends, and those friends told friends. And so practice developed, and we developed went from a two-man group to a five-man group very quickly. But there was something really lacking that I felt in my own practice. One was that we weren't learning anything in terms of research as to our outcomes. We had no opportunity to follow outcomes. And the second portion was we had nothing to do with training in new physicians. And I thought back about my own training, that so much of it was related to people who took time out of their busy practices to teach young orthopedists. And both at the University of Michigan and Special Surgery, where I did my fellowship, or my resident training, and then went on to LA County to do some trauma fellowship prior to my involvement in the Vietnam crisis, realizing that where I was depended dramatically on who preceded me and how much time and effort they took in my behalf. And I realized I was doing nothing of that. I wasn't training young physicians, and that's the heart of the future, is the young people coming behind you. So we started actually training residents from the UC program. A number of our staff here now are part of that original group. 3 of you are of that group that we trained as residents, and found that they were really highly qualified and they wanted a place to go to practice and stay in San Diego. And so we took them into our practice. And then
Because that was Kopp and Bruffy. Who was the third?
Mike Brody.
Bodie. Okay, the three of them.
Right. All three of those had done their residencies at UCSD, but took a rotation through our program.
Got it.
The benefits of that were we got into training of young people, but I realized that by this time we had specialized into subspecialties. There were now joint replacement, sports people, spine people, foot and ankle people, in which case we were in the process of training residents, and we were able to, from the university, they were willing to give us fourth-year residents, so they were really pretty well trained before that. But at that time, they changed, and they developed a new hospital, a university, and they required their senior residents to spend their time at the university hospital, and we were offered the opportunity to train first-year residents. And it really didn't fit in our program specifically because it wasn't an opportunity we could give them much operative time. These people were the patients were coming to an individual surgeon, and turning over a major part of the operation to a resident just didn't seem like that was the way to go. So we changed. Instead of taking on young residents from UCSD, we decided to start a fellowship program. And that fellowship program, interestingly, the first fellows here were not specially trained. We trained them throughout our program. We sent them from joint doctors to the spine doctors to the sports doctors and to the hand doctors.
Also in the beginning, so it was more of like a fellowship / residency and the multi-specialty training in the fellowship.
Correct.
Got it.
Because the subspecialty was just developing. Those were the years of just coming to the point that people were taking a fellowship in a specialty to hone their skills to be able to do this as a life passion. And so as you look at these names, you realize that about 90, 91, we had gone from a varied fellowship program in which we were trying to train these people to go out and be general orthopedists to people we were training to be just either joint specialists or spine specialists.
Got it.
And that really, it was a dramatic change in fellowship, but it was also a dramatic change in how we looked at individuals we were bringing into our practice and how patients were perceiving us. Patients are extremely astute, and they find out that a doctor in town is only doing spine surgery, then they said, that's the person I want to do my spine surgery. Mm-hmm. We knew this from areas like scoliosis. Most orthopedists coming out of the training program were not going to take on really severe scoliosis patients. They just didn't feel like they had enough training and enough backup, with all the support systems you need for that. And so that was already happening spontaneously, but some of us thought, we should do that in other fields as well. That if you want a good joint replacement done, do it by someone who does a lot of joint replacement.
Right. I mean, it's hard because there are some surgeons in the world that are just great at every operation. But the majority of people can be really good at lots of things. And this way, you were making surgeons that were great at a smaller number of operations, but they could treat all of those issues and problems and tackle any complication that came their way.
I think in reality, if you look at it, and you see this in the sports world, that there are some people who are superstars. You want to play tennis against Federer, you better play a lot of tennis because the guy's a superstar. And there are very few of those. Most of us can be very good surgeons, but not that.
Right.
Okay, and we want to do the best we can with our talent. And that's the goal we had, that not only did we want to do that, but we want our fellows coming out of the program to do that. We want them to well trained, take good care of their patients, and have a culture that they want to know their own results, at least their own results. And that's why the registry is so terribly important. And if possible, to participate in some portion of a training program, helping young people get the same skills and have the same ability in their lives.
because I see that. I mean, it's the nice thing here. We have, now with our two youngest new attendings that have joined the group, Dr. Jeff Wilde and Dr. Kevin Tran. That's already the thing that I'm seeing is they love the collegiality of just being able to walk into the next office and talk about something in depth that they know we really are passionate about, but then being able to share that with a fellow, in the office or in the operating room where, I know talking to Jeff when he was in private practice, it was just something he felt that he was lacking, where there was no one else to bounce those ideas off of and share a good experience or a bad experience with, and then being able to teach and share. And I think it keeps us on our toes. I hear the stories of, oh, they're a great doc. He's been in practice for 25 years, 30 years. He's just doing a lot of the same stuff the same way. But with those fellows and even our residents here that are here from the Navy now, they ask questions that you need to know the answer. So it really, that back and forth education sharing keeps us on our toes as well as helps educate them at the same time.
Totally agree. There's nothing greater to stimulate your own educational process to have people asking you questions for which you either don't have the answer or you haven't thought about it for a while, one or the other. And so, no, it's a two-way street. This fellowship training is not just one way that they do come out better trained, but you also come out a better individual.
Right. I mean, it's been, it's an excellent thing. And I mean, now we're up to 4 fellows. We have, 6, 7 of us now here, and it's become a huge program. So that's where it's fun. And even in the larger groups, when we have our weekly meetings, of being able to share all that information, it's the revision burden is the thing all residents and fellows want to see, and as we were kind of talking earlier, the good news is that revisions are going down for patients' sake. The bad news is for training purposes, they want to see more revisions. So that is the one thing that as the revision numbers have dropped everywhere, we have a lot of the fellows coming in double scrub or triple scrub on these really complex revisions just because we're not seeing the horrific failures that we saw 10, 15, 20 years ago.
Well, it's a really important point, and that is that the projection was that we would be seeing more and more revisions. But that didn't happen. And part of that is because we did the primary better. So in this process, the management of all this, to me, is you start with, as best you can, a perfect primary. And if you can get that done, your chance of failure then are much, much lower.
Right.
And I think the early phase was we just didn't have the techniques, we didn't have the materials, we didn't have instruments to make it that good, which we now have, and we're now in a position we should be able to duplicate a primary again and again and again, and have it turn out really, really well.
Every time.
Every time.
And that's the whole also idea of fellowship training and subspecialty doctors and surgeons. It's that muscle memory. It's getting that muscle memory so you can do these same procedures over and over again, but then in your brain and in your hands have the algorithm to deviate when things change from time to time. And I think it's hard, if you do a knee once a month, to remember those nuances.
Well, it is hard, again, in sports. You play a sport once a month. Your hand-eye coordination, your muscle memory isn't the same. And everybody who's world champion in the areas does more than one a month.
Right.
It's just, that's the way it is. If anything, this hand-eye coordination requires. I mean, the internal medicine people have a different kind of problem. I mean, that's knowledge-based, memory-based, and it has very little to do with hand-eye coordination, but that's not a surgeon's life.
Right.
Both are important.
We'll be back after a quick break.
Once a person is triggered, there are biological changes that happen in the brain that zap your energy, motivation, and sense of pleasure. Now, that in itself is not depression until people get into the depressive loop. It's very easy for people to stop doing things.
Yeah.
And you get into what we call an avoidance pattern of behavior. You stop doing things that give you a sense of mastery and a sense of pleasure, right? And you withdraw because the brain's basically like, hey, if you're not going to do this stuff, then I'm not going to give you the chemistry you need to want to do it.
Yeah.
So the less you do, the less you feel like doing. The less you feel like doing, the less you do. Now you're in the loop.
Now, and I don't think, a little side note too, I'm not sure a lot of the listeners know how good of a hand-eye coordination tennis player you are. Because I remember even one of our fellows, James Cameron, was here, but I think it was after you had stopped operating. But I remember him telling me, because he was a very competitive tennis player, that you guys were going to play, and he thought, I have to go easy because I can't go out there and beat the boss. And then he told me afterwards he was struggling just to keep up with you, that you had played so hard.
Well, no, I'm not. I'm a reasonably talented person who has taken the sport seriously since I was about 35 years of age before I took it up. So you're never going to be really great. On the other hand, if it's something you do again and again and you try to improve, you will. And it's been a gift for me because physically I'm still reasonably healthy, have no real significant problems, and playing in tournaments up to the national levels, it's been fun. It's been exciting.
Yeah, it keeps you busy, and it keeps the competitive spirit going.
Absolutely.
Now, so when we were talking about fellows, and we were talking a little bit about this earlier, the idea of what we used to call back then your Super Tuesdays. The Super Tuesdays were the days where you ran 2 rooms. And there's always a lot of discussion, should I run 2 rooms? Should I not run 2 rooms? Even young doctors going out. So what sort of tips, or when would you recommend somebody even think about doing 2 rooms, or what problems have you learned from running 2 rooms for all of those years?
Well, running 2 rooms has a whole set of issues that come up that are different than running 1 room. And in most people's practices, running 2 rooms is not really realistic and still give the same quality of care to every patient, because that should be your goal. So when the issue came up, it had to do with 2 issues. We were not managing our volume well. We had more patients than we could manage. They were unhappy waiting 6, 9, 12 months to have an operation. I thought that was unrealistic for them.
Yeah.
So I thought, is there a possibility that we can get more patients processed but not lose any of the quality? So that's where the concept came from. You can't do this without a fellowship program in which these people are already trained. They're going to be in the room with you. They're already trained orthopedic surgeons. So to be able to do some of the opening closing should not have compromised the patient's outcome. So that meant that you could cut a fair amount of time off, because we realized that the turnaround time to keep the cleanliness and the issues of operating room procedures was really unwieldy. So that the time between one operation and another, there was a lot of downtime. And if you could eliminate that downtime, and keep yourself moving and not compromise at any point the patient's outcome, then that may have been a reasonable goal. That's how we started. So it was experimental. And I would say that for the most part, it worked really, really well. I have one memory of one case. And one of the issues we decided upon was that we would do nothing but straightforward primaries. So in the days that I did 2 rooms, 6 to 7 cases, they were always straightforward primaries. These are not revisions. And the one mistake I made in my career is I did what was, in my mind, was going to be a simple revision, which it never is. Mm-hmm. So I knew better, and yet I had one case in which it went from a very simple revision to a complicated revision, and that really complicated the whole day. No one got injured from it, but it does mean that I had to go back and reevaluate my own criteria. Why am I doing a, quote, simple revision when you know that they sometimes are not that?
Got it.
So those were the criteria, and I think we looked at the results after 2 or 3 years of doing this, and we felt that there were no difference in the clinical outcomes, and that if we stayed to the process that we decided on originally, which was to do simple, straightforward primers, it worked really well. And it's emotionally draining because you have to finish the operation, go and talk to the family and tell them exactly how it is, and turn right around and you're right in the middle of the next operation.
Right.
So you have no time to recover. You have no time to sit down and reflect. And so you have to be ready for that kind of intensity. And doing it one time a week, I thought we could do it. I'm not sure if, I don't know that anybody's trying to do this twice a week on the same doctor.
Not here. No, not here. Just, it's, I think for right now, it's one day every other week, every other Wednesday. Yeah, I mean, it's one of those things because I've thought about it. I've never done it, and it's for a lot of the same reasons that you say. I mean, I saw all the benefits, pros and cons of when we did it here. I do remember, honestly, when I was in med school residency, working with Dr. Booth. I mean, that was the slickest machine ever because, like you said, I mean, he had to have good residents or a fellow, and he had the RNFAs that worked with him. So you would be in a room, and patient would be under spinal, ready, and when you saw him scrubbing the hands, the S mark went on. He'd walk in the room, cut, procedure's done, throw a stitch. He could go to the next room and with 100% certainty know that next patient was already in the room, on the table, same team saw him scrubbing his hands, S mark, cut, stitch, came back, and by then the first room had already been turned over. So there you needed so many facets of perfect anesthesia, perfect turnover team, and like you said, cases that were identifiable as being straightforward, but it makes it difficult. So for me, I have that difficulty of, could I leave and talk to the patient and not have the chance to talk to the other patient before they went, under anesthesia? It just doesn't fit, I think, with my psyche at this point. But for patients that want it and doctors that are high volume where the need is there, and that's the thing. I mean, you see in Europe, I mean, they're 2 years behind getting patients in. So these patients are suffering. So in the right setting with the right team, that you need that team approach. It can be a very good thing for the patients.
Well, and you're talking about one of the geniuses of our profession. Excuse me, he really was. He was technically excellent. He had organization that made the difference. And so you're just going through why it can work and why it may not work in everyone's hands.
Right.
Because he was one of our superstars. He was one of the pioneers in bilaterality, and he was one of the people that I looked to in making my decision to be able to do this. But I don't think anybody had ever gotten a better results than he did, for the reasons that you just quoted. He had an organized team that was able to carry this out day after day after day without ever compromising the quality of the patient's result.
Yeah, it was almost like the Henry Ford of knee replacements. It was just so streamlined.
Now you're getting to another issue about why do you have groups like the Knee Society and AUKUS. Those are important, very important organizations. They allow you to mix with people who are on the firing line. They are the ones who are on the outskirts of making new decisions, moving the profession forward, not just doing something new, but actually making a difference with a new aspect of the operation. And those people migrate to a certain sort of category. It's the same thing in tournament tennis. You get to a certain level, and then there's always a level ahead of you. And so that way you improve your own game. It's the same thing here. You mix with the people who are the movers and the shakers. Yeah. So it's important that we keep that alive without really making it an elitist group. You don't have to be in the Knee Society to be able to do really, really good knee surgery.
Right. Yeah, but it's like sports. I mean, you play with people that are way better than you. It just forces you to get better. And you surround yourself by people that are better and smarter than you. It just stimulates you to get better and smarter and work harder. You want to be like those people around you.
Right. No, you want to do that. You want to be that kind of a person. You always want to be getting better at what you do.
Right. Now, one of the things we were also talking about earlier, and it kind of fits into the idea of training fellows and running to rooms and having comfort in the level of their training. And because I remember even when I was with Dr. Lotke and patients would ask in the office, well, I don't want a resident working on me, and I thought he actually described it very well. I always credit him when I tell my patients when they ask the same question about the fellows, but he described it as this is a multi-hand operation. and whether or not, my hand is on the instrument jig or the saw or the drill, or the resident or fellow's hand is on the jig or the saw or the drill, the operation is being done the way that I want it done.
Right.
And they're an integral part of the operation, but I'm there and basically orchestrating everything. And I thought that was a great way of explaining it. But like you said, they come along with different skill levels. So we see some fellows that come through with excellent high skill levels. I find they could do a primary on their own, without any issues. And there's some others that come out of training programs that, are still learning some of the basics and nuances of primary. So that's always been honestly my difficulty. I think I'm a better teacher at the fine nuances, and I'm still learning how to teach the more basic parts, when they come through without those skill levels. But what are the things that you saw or difficulties that you had in teaching such a varied level of skill of fellows that would come through the program on day one?
Well, I think your point is primary here, is that in total joint replacement, it's a four-handed operation. Okay, so you can take over more or less depending upon that skill level. In devil's tennis, you may have to take over more of the court if your partner is weaker. And the same way, if you happen to be weaker, then the other person takes over 60% of the court. So the delight of joint replacement is a four-handed operation. And consequently, as you as the leader, you can take whatever percentage of that as you need to, depending on their skill level. I found teaching arthroscopy was extremely difficult because it's a one-person operation. And if you gouge the articular cartilage it's gouged.
Right.
And it remains forever.
Correct.
Okay, so you are in a situation where if you turn this over to someone who has lesser skills, then you're going to have more gouges. That's true, and it's necessary for the better good of mankind, but it isn't better for the individual patient. I found that extremely difficult to do, and therefore I didn't teach arthroscopy.
Got it.
And in dealing with my teaching with some of the really skillful arthroscopists, none of them were particularly good teachers because they had gone through the learning curve. They had, in fact, scuffed some articular cartilage, but they didn't do it anymore. And so that I find quite different than joint replacement, in which you, like I said, this is not a one-man operation. And consequently, who takes a greater percent of it depends on their skill level.
Right.
So I can be there, get the same quality outcome, and I might have participated more with one individual than the other. And in teaching, you also have to be able to tell your trainee, you're at a point in level that I can let you do this much, and when you show increased skills, you can do more.
Right.
And I have to face it. You have to do that. If a person doesn't have the skill level, they shouldn't be doing it.
Yeah, that's always the hard thing. I mean, especially here because it is a private group. It's in some ways, patients are coming to the clinic for a particular surgeon. It's very different than being brought in by ambulance with a trauma to a university at 2 a.m. And I think you almost assume at a teaching hospital the residents are going to be involved. So it's hard to let someone, experiment or learn. And that's always been the hard part of difficulty. I mean, it's great when someone comes in with great hands, but there's a weird feeling of not letting someone do more because they don't have the skill level yet, but it is for the benefit of the patient and in the hopes that the speaking or the showing learned that muscle memory. And that's where I think sawbones are great. I do think, and I hope, I saw at the Academy this year, a lot of companies that are coming out with the virtual reality of allowing residents to do 100 reps of a knee replacement or hip replacement through virtual reality. And it'll be interesting to see how that transitions to their skills in the operating room. I mean, I saw that with the skydiving world. When trying to teach people to skydive, it was really hard in the air. You got 50 seconds. But now with the wind tunnels, you can have these students that, spend 20, 30, 40 minutes in a wind tunnel, and then they jump out of an airplane, and they're awesome because they've had so much practice in this kind of, it's not a true virtual reality, but they've practiced it outside of that normal environment. They don't know how to fly a parachute yet, but at least they can fly through the air. And I think we're going to see that in the operating room where that skill level virtually may transition over to more skill for surgeons in the operating room once they get there.
No, I think so. And this virtual reality technology is just coming into the forefront. I think it's wonderful. I mean, in terms of using a joystick, for instance, to be able to appreciate when you penetrate the second cortex in a fracture treatment. Yeah. That sensation of coming through the second cortex is a more skill you don't want to get in taking care of patients.
Right.
You want that beforehand, and you can now do that. And the use of, young people know how to use joysticks, and that was all brand new for us. But that's for you folks, that's a slam dunk.
Yeah, I mean the video games and that technology's there. That's where my fascination more recently has been with the augmented reality platforms in the operating room and trying to get them in here, which has been another issue with the hospital here and just getting them to approve it. But I think that's kind of a neat thing of being able to see the heads-up display. And I know the first time we trialed it as a group, a lot of my older partners just went, no way. Like, I can't put this headset on my eyes and look and see what I'm doing. But we're used to it. Right. We're used to multiple screens and doing those things. So I think in the future it's going to have the ability to offer so much data that for some people could be overwhelming, but hopefully data that we can use in the future to lead to better outcomes for the surgeries.
Well, no, I totally agree. I do think that joint replacement is at a point in its evolution that there really is a standard that is hard anymore to change much. I think right now we're in the reverse, that we're used to trying to change things all the time to be better. Mm-hmm. Okay, but we have an operation that's successful so many times that if you change anything, the chances are you're going to make it worse.
Right.
So that's both a positive and a negative. You say, we don't want to be doing the same thing you're doing 10 years ago, unless what you're doing 10 years ago has a close to 100% success rate. If it does, then what is the world you're changing it for?
Yeah, stick with it. It's working.
Right. It's hard to improve on perfection. So that it's a dilemma, because you never want to say, well, keep doing the same thing you're doing for the rest of your career and never learn anything new. On the other hand, there are areas in our field that still need lots of improvement. And as you talked about, the complicated revision is still a difficult, and the results are nowhere near what a primary is. So there's a lot of area there to improve on.
Right. And I think, even a lot of the technology that has come out has been so helpful. I mean, a lot of the fellows we ask now, I mean, they've never seen, a tri-flange cup or a cup cage construct. Even in the hip world, trabecular metal has just been such a huge change for our acetabular revisions. And then on the knee side, I mean, having these sleeves and cones, it's just been such a huge change from, and I remember making, tin snips and wire cages and impaction grafting the tibia for these large uncontained defects. Now you can drop in a sleeve or pop in a cone, and all of a sudden you've completely changed that pore structure in the tibial bone or the metaphyseal bone in the femur, and you have this great stable construct that 10, 15 years ago we were doing things that we really were leaving the operating room with our fingers crossed going, I hope this works.
Absolutely. Yeah. And those difficult cases are still plenty of opportunity for advancement.
Right.
And they continue to be.
Yeah, and as we talk about advancements, we were just kind of briefly talking during a little break about the longevity of implants. We were talking about how long they last, which is a great thing. You had just mentioned that one of our partners saw one of your patients back 30 plus years out. I saw one of the other surgeons that had worked here in town around the same time that you were working. His patient was out 25 years. I mean, we're doing these operations that are working in people for 30 plus years, which is pretty amazing.
It really is amazing. I mean, those are exciting outcomes, but we still have to know what those are. Is one of your implants lasting 20 years and another one lasting 30 years? If so, we need to know that and go to the 30-year rather than the 20th-year.
Right. So we can get those people to basically, outlive, or the implant outlive the patient, which is the best case scenario, right. And then never have to have it done again. Now, earlier this morning, too, one of the other questions we talked about discussing is doing simultaneous bilaterals. And you had asked when we were starting, had I ever done bilateral total hips? And I stopped you because I said, I'm going to hold off on that because I remember in fellowship and towards the end, getting ready to start my practice, one of the things that you did say about doing bilaterals was, you probably shouldn't do them in your first couple of years, get your feet wet. So my first day here was a knee scope followed by a simultaneous bilateral total hip, ceramic on ceramic. And it was a lady because back then, if you remember, in the fellowship, we ran our own clinic. We had 1 day a week where as a fellow, we ran an intake clinic. So for a year, I saw patients that I treated, and then when they needed surgeries, they would be referred to the surgeon that I was working with. So this was a lady that I had followed for most of the year, and she knew I was going to start work here. And she just decided, I want to have both done, and I want you to do it, and I'll wait till you start. So, yeah, she was my first patient. And I've taken care of her for years. She came back a few years after that. I did bilateral total knees on her. But like we were talking earlier, I rarely do bilaterals now. And I remember at AUKUS, like every year they would do the informal survey of the audience. Who does bilaterals? And almost everybody would raise their hand. And then who does less now than they did previous years? And, a majority of hands would go up. So that would be me. I mean, I used to do a lot of bilaterals. I do very few now. But what are your thoughts? I mean, what were your decision-making on who to do a bilateral on? Who did you avoid doing a bilateral on? And how did you predict what the outcome would be?
Well, you have to understand that this is a process. This doesn't change overnight. The first thing to even consider bilaterals, there had to be a change in the overall complexity of surgery. That included anesthesia and changing from general anesthesia to block anesthesia. The operation became more standard, and therefore we could get it under an hour in time normally. So all those were part of the decision-making process as whether you could do bilateral at the same setting. It depended upon your team. You talked about Bob Booth. You had to have a team of people there that were qualified to be able to do this operation and do it twice in a relatively short period of time so it didn't increase the risk to the patient. Mm-hmm. So during this process, we began to develop criteria for who we would do and who we wouldn't do. And basically that came down to the fact the patient had to be, one, healthy generally, didn't have other complicating medical problems. They had to be inspired. They had to want it. This isn't a question that you want to talk them into it.
Right.
It's a question that this is a patient came and you say, look, I'm a working person. I can't take out 3 to 6 months to get better and then come back again and do the same thing again. Mm-hmm. You're talking about a year of my time now. I don't have that time.
Right.
So that was one issue. Two, as I indicated, they had to have good health. You can't jeopardize their health by the type of operation you do. But in certain set of circumstances, we thought we could probably do it, and we tried to keep track of how our patients did. And generally, the overall results, when looking at them, we couldn't differentiate the end result. So in that setting, it was a good experiment. Did we ever overwhelm a patient? I remember overwhelming one patient. It just was too much. Mm-hmm. And it turned out that it required a long rehabilitation of this patient, much longer than in other patients. And consequently, I thought that was a negative experience.
Right.
Turned out all right, but it took a lot longer to do. And therefore, so it's a call. I don't think everybody should be doing bilaterals. They need to first feel comfortable. They have to have a team that can accomplish this. They have to have anesthesia. They can do block anesthesia. General anesthesia for do bilaterals probably has some negative outcomes. That's still in question, but I think there's enough evidence now that general anesthesia over a couple of hours is detrimental. Mm-hmm. And so I would like to avoid that. So you have to have an anesthetic team that's ready to go and can do blocks. Right. And do them effectively. I think there is a place for bilaterals, but it isn't for everybody's practice, and it isn't for every patient.
Right. Yeah, because I think with TXA now, that's been a huge game changer because it was almost every bilateral. Back then they would donate blood and they would almost always get a transfusion. And with TXA now, even with a bilateral, transfusions are rare. The other thing is the pain management. The pain management has changed so much. I think the pain is much better managed now than it was, 10, 15 years ago. So those two things have made it more manageable for patients. The thing that I've found the hardest is that just trying to read a patient, like you said, is the patient wants it, but trying to assess a patient's pain level, their resiliency, which is a big word we're hearing about now, that some of these patients that have higher levels of resiliency may tolerate pain and get through rehab better. But that's always been the hard part for me, is picking the patient, because they either do, like you said, they're positive, they're proactive, they want this, they do it, they do great. And they're the people that always say, wow, they did both and they did better than someone down the street that had just one done. So there's definitely a mentation and a biology that we can't identify, but those patients do great. But yes, the sicker patients, and I get these patients that come in, they're obese, they're on a blood thinner, they have heart disease and diabetes, and I just look them in the eye and go, no way, too high risk, not going to do it. Consider doing one at a time.
Well, that's part of your maturity, and the fact that you've now done enough operations to know what you can do and you can't do. You tackle one of those patients and do a bilateral, you're looking for a disaster about to happen.
Right.
And you have mentioned the two things that I didn't talk about with both pain control and the blood transfusion issue is dramatically changed. I mean, we had an elaborate blood donation program, and EPO was given, and this was to try to keep the transfusion rates down. But that's when hepatitis and AIDS were a part of the complications of blood transfusions, which now have been basically eliminated. Mm-hmm. And so not only do we not give much blood anymore, but the blood we give is very safe.
Right.
So all those things go into this operation. Can you do this operation bilateral and have a successful outcome? And your point, you have to have all those things in alignment to make it work. And if it is, it's a beautiful operation.
Yeah, and then the patients love it.
Oh, the patients absolutely love it, and it halves their recovery time.
Right.
In half. And you realize that, that the total joint replacement, two different types, hip and knee, they recover quite differently. And for lots of reasons, but quite differently. So when you have the time, whatever, that's really important.
Right. It's interesting too. I think a lot of people look at bilateral hips and bilateral knees, and they all seem to have this perception. It's like outside of our field, but they have a perception that hips is going to be so much harder. And I don't know why the perception is there, but the bilateral hip patients get up and walk, just because hip patients in general just recover easier, quicker, faster than knees. But the bilateral hip patients, which seems like a scary operation, definitely recover even easier than the bilateral knees. But there is sort of this perception, this misguided perception in lay people that they think, oh, bilateral hips, I would never think of doing that, but I'll have bilateral knees done.
Well, to some degree, that's because knees came along sooner to do bilaterals. And in my case, I didn't really get into bilateral hips because I did them on their side. I didn't do the anterior approach to them. And consequently, it was really difficult to change. You just operate on the patient and had to turn them over on the operative side and change the whole draping and all that. That they don't do that anymore. I mean, that's gone by the wayside.
Right. And it's interesting because even for the young people listening, there's not great studies. It makes it difficult because a lot of the studies that you read, you have to scrutinize, and they'll talk about bilaterals versus staged, and you have to tease apart the data because a lot of groups, it's retrospective, and they're looking at, you were healthy enough, we offered them a bilateral. You were not healthy enough, so we did it staged, and the staged plus the staged complication rate doesn't always equal the healthy bilateral. So that's going to be the interesting thing going forward, of having more patients in these databases to be able to look back and quantify based on ASA, categories or medical comorbidities, and really compare apples to apples and get a good assessment of what is the increased risk, or, is there a different risk stratification for simultaneous, versus bilateral? Should we look for certain disease entities more so in one group than the other? But I think it's something that's going to stick around, especially with how many surgeries have been canceled worldwide during this COVID epidemic. There's a huge backlog everywhere. So this is something that a lot of places may have to consider, of deciding who do we do bilaterals on just to speed up their recovery process because they've already been suffering for 2 years?
No, and again, back to the whole issue of bilateral, there's so many different factors. Most of the literature is comparing bilaterals with unilaterals, which is, to me, has been an idiotic comparison because you're talking about 2 knees versus 1 knee.
Right.
Not 1 knee done now and 1 done later. So you have to double all of the complications of a single to come up with the same numbers. But most of the literature is filled with 2 versus 1.
Right.
Which, of course, there's going to be more complications in 2 than 1.
Yeah.
But it's going to be more complications in 2 than 2 done simultaneously or 2 done independently.
Right. And those are the studies that we really need more of to really assess it.
I think it's at a point now that it's going to be close. I don't think there's enough differential. Have you seen in your practice of people coming back for one reason or another, more people coming back for bilaterals than with unilaterals?
I don't. It's just complications. No, I think with bilaterals, and again, all of us are different. I'm very selective in who I do. Like we were talking earlier, I do significantly less than some of my partners. But I do find there's a lot more questions, like patients that have bilaterals. They call because they have more, wound questions or pain questions or sleep problems or therapy issues. And we bring them in and we check it out. So there's a little bit more work on the back end for those bilaterals coming back. But it's hard because, you do 1 knee and then someone comes back for their other knee and they think, oh, wow, that was so tough. I'm glad I didn't do both at the same time. And then you do both, and the next person who says, oh, I'm so glad I did both because I would have never wanted to do this, one followed by the other. So even the patients don't help give me the answer as to who to do what in which patient.
They don't, and that's life.
Right.
This is how the patient sees it.
Keeps us on our toes.
Right, it absolutely does. And no matter what we say, oh, this patient had a great range of motion afterwards, had a great result. When the patient says, this thing still hurts.
Right.
Okay. And from their point of view, this isn't a great result. And so this is patient perceived and reality.
Right. And that's such an important thing is, what their outcome is from their perspective is so much more important than our findings. And that's where these patient-reported outcomes are really going to give us a good understanding of, are we doing a good job? We all love the x-rays. Oh, yeah, x-rays look great.
Right.
Patient's like, I'm in pain. I can't bend my knee. I'm still limping. It's not really a great operation.
Because the x-rays look really good.
Yeah, and that's the thing we have to kind of figure out down the road. Well, the other thing that we were kind of talking about maybe covering, and we could talk forever on it. We could talk forever on all this stuff, but, just the idea of robotics in the future. I'm interested in augmented reality and robotics, and we were talking about x-rays. It was something that we talked about earlier where I still have this belief and philosophy that I do not believe that we should make every knee the same. With robots, someone says, I put all of my knees in this mechanical alignment, or I cut my tibia at this degrees, my femur at this degrees, and this is the balancing number color I'm looking for on whatever system I'm using. And to believe that all of the different people body types that we have should all have a knee that is identical still just doesn't make sense to me. It's the idea of the people that believe in gentleman's varus. But we need, I think, either these computer data programs with robotics that are capturing the data, then combined with the patient-reported outcomes, and maybe some other preoperative information to better determine a valgus knee should be left in this many degrees of valgus, or a varus knee in this many degrees of varus, or someone that's loose-jointed, maybe the knee should be a little looser versus, a short, stocky guy, which we all have this art of, oh, my short, stocky guys, I put in a little tighter, or someone says, I leave them a little looser because I think that they're going to get tight. Those are those big questions that we don't know. So I'm hoping that down the road that some artificial intelligence, deep computer mind thinking can then tell us this patient's knee should be put in this position and alignment to make sure their patient-reported outcomes are the best, not just that a line drawn between their ankle and their femoral head intersects the knee where I want it to be. So I'm wondering your kind of thoughts on seeing this future of robotics and where it might take us to make that 20% unhappy patients 10 or 5%.
Well, you're bringing to the issue, where does robotics fit into this plan? And as you indicated, there may not be a perfect position, 3 degrees of varus, or not, or an absolutely parallel tibia. That may not be the answer. I think if robotics is going to play a role, which I think it probably will, both because of the marketplace, that's a true reality you have to face, and the fact that it is more precise than people doing it by hand.
Right.
Robotics can reproduce what it is you want better than if you'd use your own hands. So your real question, and that you brought that up, is 5 degrees this way or that way the real ideal? And we don't have that answer. So every surgeon is using the same concept that you are. Should every patient be treated the same way, or should I treat a overweight individual who was in varus before? Should I treat him differently? I don't think robotics is going to answer that question. I think robotics only can put it in more precisely. And in that setting, I think it has a role. If you say, I think it should be in 5 degrees of varus, and that's what I want, I think robotics can do that for you.
They can put it there.
They can put it there better than we can put it there.
The question is, should it be there?
Correct. And the question is, does it really actually make a difference?
Right.
In other words, this is an operation that doesn't stop today. It's living. The bone is changing, and it's adapting, etc. So it's not just like woodworking, in which when you finish the project, it's finished. This is not the case. And since the bone is continuing to adapt, is 1 degree difference ever going to make a clinical outcome difference? I doubt it.
Right.
I don't think we're ever going to figure out 1 degree. I don't think we have a technique to show 1 degree.
Right. It's so hard. And that's what I mean, because even the original attempt at making anatomic alignment, which is kind of like a precursor for now today's kinematic alignment, a lot of the failures, those bone cuts were a lot thicker. The plastics were thicker because the plastic was poor. Maybe now you can put them in more anatomic. Maybe you can put them in kinematic. And then it comes down to the kinematic camp with a medial pivot. How much of it's the kinematic alignment? How much is it the medial pivot? It's so hard. And this is where I really believe we need a computer-generated thinking program, because there's so many variables. I even just talked to the Zimmer guys the other day, and it looks like with their medial congruent knee, that actually has just bypassed the popularity of the PS knee. So they're actually using more medial congruence than PS knee, and then CR falls further behind that. And it's the whole question: like, is medial congruent, medial pivot better? Is it more forgiving? Maybe in surgeons' hands that don't balance it as well. Is that design just more forgiving so the patients feel better? I don't know. I'm not sure anybody does know.
I don't think anybody does know. Those are questions that are very complicated to answer as well, because even chasing down patient outcomes is difficult to do. In terms of even getting patients to come back for a long enough period of time to really study them, it's hard. I mean, if a patient has really good operation and a very good successful operation, they see no reason to come back and see you.
Right.
And you can understand, why do I want to go back and see a doctor? I got no troubles. I got no problems. I got work to do today.
Yeah, good, fine. And that's, because even now there's a few studies that are coming out saying, this regular follow-up that we've been so used to for x-rays really isn't necessary. It's a waste of money. So that's good in some ways, but bad in other ways, because we then never figure out how our patients are doing if we don't see them, because we've said, it's so good, don't come back. But we do want to hear from them every so often, just to make sure they're doing okay and make sure that, the implant's okay, especially if we can identify an early failure, maybe polywear before osteolysis develops, that leads to the need for some of the revision of the metallic component, whether you're talking about femur or the knee.
And that comes back to the registries. The national registries have been able to pick out early failures much better than we have without a national registry. So that we are behind other countries in that sense, that you can pick out failure rates much quicker.
Right.
Success rates are much more difficult, but failure rates, and that's what we really need to know, because John Insall, who obviously is one of the giants and started the total knee replacement, may not have been the first one, but he was certainly one of the early ones who I had a chance to train with. When we looked at the results of his first knees, and then he went to more constrained using a posterior cruciate substituting design. And I asked him early on, John, your results were so good in the first series, why did you change? His answer was a practical answer. You can't stay the same. Companies can't exist by just doing the same thing. They have to go new.
They wanted something different.
They want something different. And so we went different, even though we didn't have any indication that what we were doing to start with was poor. And that decision has still never gotten a resolution. There are still arguments going on versus, constraint that you put in the implant.
Right.
And since we don't have that answer 35 years later, it probably doesn't exist.
Right.
So you probably are not wrong in doing either one.
Yeah, as long as you do them well. Whichever one you do it well.
Right. And my argument. My argument is that if in fact the trunnion is useful, then it must hit something.
Right.
If it hits something, that's bad.
Right. You don't want the post to hit something, but in a PS&E, the post has to hit something. So
if it doesn't hit something, you don't need it.
Right.
So that's my argument. But the argument from the other people is, this thing works as well as your operation.
Right.
And it works, and it's easier to train people to do because you don't have to balance the posterior cruciate. So
right.
I can get the same result you can, and I don't have to balance this posterior cruciate.
Right.
And that argument is sound.
Yeah, it makes sense. And it was, for me, it was a great, great sequence in my training, coming from Philly, which is so predominantly PS, and then training here, which is so predominantly CR. And it was great because I was able to see so much of both. And, what I found, the fallacies of, CRs are so hard to balance and expose. And they're not, if you do them right and you do it well. The thing I always hated, though, was pulling off PS femurs and doing a revision. Pulling off a CR femur to revise, there's so much more bone. And I'm so much happier. And, I saw, not a lot, but, you cut the box and somebody goes to put the femur on, not so artfully, and breaks a condyle. It's pretty rare to break a condyle putting a femur on a CR knee, but when you have a huge box cut, that risk of a condylar fracture, cam jump, dislocation, jumping your cam. Again, not poorly done, probably loose inflection, but an entity that doesn't exist with CR knees. So I always tell people if you think CRs are bad, they're not bad. They're just different. So whichever you do it well, and the patient will do fine.
And one of our early failures, which we didn't recognize, is that in accepting the cone effect of the proximal tibia and the fact that the volume of a cylinder is 3 times what a cone is that we cut the tibia, we cut too little of the bone off the tibia. Mm-hmm. We jacked the joint line up, and in so doing, we made it too tight if you kept the CR, if you kept the posterior cruciate ligament.
Right.
So in our very early results, we could not match what people were sacrificing the posterior cruciate. Once we realized that you could take more of the tibia and still not sacrifice that much of the cone, then that stopped.
And keep the joint line so important. Primary revision, restoring the joint line is key for that range of motion, but even more so in the CR knee. And that's where I think it's definitely more difficult to balance the cruciate retaining designs.
Absolutely.
Yeah.
Because the knee is so responsive to the ligaments,
right,
which it isn't in the hip. So that if you don't get the ligament balanced properly, and if it's too tight, it's too tight.
Right.
And it stays too tight. And I don't care what you do in the rehab. You can do it forever, and you can do it perfectly forever. With the most dedicated patient, it's not going to work.
Right.
And we did that. We jacked the joint line up in order to preserve more tibia. In so doing, we made them too tight. Mm-hmm. So if I had to do my early ones over again, I would have said we're going to take more of the tibia and therefore get the joint line proper, and then this operation is reproducible again and again and again.
Right, and it's just, it's abiding by all those parameters. Because I even see that now. I rarely go to PS, but that becomes a good indication where, stiff knee, and we're going in there still tight in extension, wind up cutting more distal femur to balance the extension gap. And I'm letting the fellows know, what did we do? We elevated our joint line. Okay, what are the kinematics like? This is one where we may need to sacrifice that PCL because now we've elevated the joint line and we throw off the kinematics. But I think it's one of those things that people aren't always thinking down that part of the algorithm. They're just thinking flexion, extension, balancing. And there's a lot of other steps involved that when you start messing with things, you alter the kinematics elsewhere.
Yeah, I believe that's true.
All right. Well, I mean, I think we've covered a ton of stuff in these past 2 visits. I mean, we've covered, your history, how you got here. We've talked about knee designs, the history of knee surgery, simultaneous bilaterals, 2 rooms, teaching fellows, robotics. I mean, you name it. Anything else that you really want to share with listeners?
No, just the listeners. I mean, I think the future is still going to be biology. As good as these operations are, and they should never, I don't think ever will be a time frame when we won't be doing them, but I think the surgeon's role is going to change. He's going to be doing biologics. It's still going to take surgery to do it, to put it in, and how to put it in, and how to put it in properly, and so forth. But I think I'm excited about the next stages. I'm excited about what we can do now, and it's just glorious, but I also see a time in the future that we don't have to do the same kind of, in the size of the surgeries that we're performing now. When that's coming, as you know, our lab is very active in this, and we haven't hit prime time. We don't have the product. It's not here. It's not. And when somebody says, "When is it going to be here?" It's going to be here at the right time.
Right.
We don't know when it's going to be here. It could be soon, and it could be a long, long time, because we don't know where the finish line is. When you run a marathon, you know where the finish line is. And you know if you can get there, you've finished. We don't have a finish line.
Yeah, you can't see it yet.
We can't see it yet. So it could be a 100-yard dash away, or it could be a marathon. And I think as we also improve our technology of what we're doing today, we still have to be looking for the future. And that's in the young person's mind, that's where it is, because they're always looking forward.
Yeah, always getting better. All right. Well, thank you for training me. Thank you for talking with me today and sharing all this great information. And we will all wait patiently while you and Dr. DeLima figure out the solution to arthritis with cartilage transplantation.
You may have to wait a long time.
Yeah, we may wait a long time, but we'll wait and we'll keep an eye out for it.
And to those people who pay their taxes year in and year out, you should feel 2 things. One, that we're trying to use your money effectively. So when we get our NIH grant, which comes from taxpayers' dollars, we do appreciate that people are paying for this. And we are working hard to try to make those tax dollars be appropriate. Right now, I can say we haven't found the answer. Mm-hmm. So when people ask me, should I invest in this in terms of more tax dollars? Should we have more taxes go towards this area? I'm not sure that I can answer that, because until we hit prime time, until we really change patients' outcomes, it's only theoretically beneficial.
Right. Yeah, it's just such a disabling problem that, if we can come up with a cure for it one day. I mean, like we just saw the Nobel Prize. I always tell people, we just saw the Nobel Prize being delivered in multiple different facets for all the different, aspects of our world. But one day, someone's going to win that Nobel Prize.
No question.
This exact issue.
Can you imagine? This affects more people than any other disease process in the world.
Yeah.
There's no other disease process that affects people like this. So if you were to change the whole way this is managed and treated, of course it'll get the Nobel Prize.
Yeah, one day.
One day.
Hopefully not too far down the road, but one day soon. All right, Dr. Colwell, thank you again. You've been listening to Dr. Colwell. I'm Adam Rosen. Thanks for listening to the Total Knee Tips and Pearls podcast. Until next time, stay safe. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.